This is Maddie Mezzi, and we are presenting today a module called Risk Factors for Poor Outcomes in Older Adults, Iatrogenesis, Frailty, Geriatric Syndromes, and Atypical Presentation of Illness. Let me just say a little bit about this module. This is an online module of the Consortium of New York Geriatric Education Centers. It was developed by faculty and staff at the Hartford Institute for Geriatric Nursing at the NYU College of Nursing. This module will be archived and can be accessed at any one of the following three websites. The direct access would be to go to the hartfordIGN.org website and go to the e-learning center, and you will learn more about that later. The Consortium of New York Geriatric Education Center is comprised of 4 academic partners who have come together to really focus their efforts on training for interdisciplinary health and human services professionals throughout New York State. This is a project funded by HRSA, the Department of Health and Human Services, Health Resources and Service Administration, and the participating agencies in this project are the Mount Sinai School of Medicine, NYU College of Nursing, Columbia University, and the GREC, the Geriatric Resource and Education and Clinical Center at the James J. Peters VA Medical Center. I'm Maddie Mezzi, and I will be the faculty member for this module. I am a professor emerita at NYU College of Nursing and continue to be associate director of the Hartford Institute for Geriatric Nursing at NYU. Let me just start by giving you an outline for this module, which will take approximately an hour to complete. The first thing that we're going to talk about is the context of care for older adults, and then we're going to talk about 4 areas that place older adults at risk for poor outcomes, poor health outcomes: iatrogenesis, frailty, geriatric syndromes, and atypical presentation of illness. We'll then follow these areas with a brief discussion of the particular risks of any one of these untoward events for older adults who have cognitive changes and which make them a particular at-risk population. The objectives of this module are shown in this slides, and what we hope is that at the end of this module you'll be able to describe aspects of the context of care for older adults that places them at risk, describe the phenomenon of iatrogenesis, the components of frailty in older adults, the importance of geriatric syndromes, and the characteristics of atypical presentation of illness in older adults. And then hopefully you will also be able to explain why cognitive impairments place older adults at increased risk for any of these events. So let me start out by describing the context of care for older adults that have particular relevance for these 4 areas of risk. The first is the phenomenon of the fact that we now have a aging population, but specifically that we have a phenomenon of a marked increase of older adults who are what we call the old. That is, older adults who are now 80 or 85 years of age and older. And this is the fastest growing group of older adults in our country and also worldwide. Currently, As you can see in this slide, there are 70,000 centenarians in the country today. That's in the U.S. But this number is expected to increase tenfold by 2050. And there are researchers working on mechanisms, whether they're genetic or whether they're medications, that will make normal life expectancy reach to over 100 years of age. So this phenomenon of the very old, older adult is going to continue and expand over the next century. And this is the population that's particularly at risk for the phenomenon that we're talking about today. Now, I do want to back up for a minute and remind us that most older adults are really healthy and active even into very old age. And this is a group of surfers in California, and all of them are active surfers, and they're all 70 years of age and older. So I wouldn't want to leave you at the end of this module with the mindset that most older people are very frail and very at risk of geriatric syndromes. There are many, many people who are aging into very old age, healthy and active, functionally vibrant, with a very good quality of life. This is true for all populations, and this photograph evidences 3 people who are themselves marching into old age, and they are very good friends. And friendships and companionship is really a hallmark of healthy aging. On the other hand, most of us in the healthcare professions are taking care of older adults who have multiple chronic conditions, which places them at risk for functional declines, cognitive declines, and which really restricts the vibrancy and the kind of quality of life that they are experiencing, especially as they get into their 80s and 90s. Older adults these days are the predominant recipients of health care. The majority of care of older adults in ambulatory care are people who are 65 and older. 48% of hospital patients are 65 and over. Most overwhelming majority of people in home care are people who are 65 and older, and 90% of nursing home residents are 65 and older. And in nursing homes and home care, the average age of adults that are under care of home care and nursing homes exceeds 75 years of age. So we are taking care of, predominantly in healthcare, of a very much older population. And we at the Hartford Institutes have begun to talk about older adults as the core business of healthcare, so that even in ambulatory care, older adults make up the predominant group of patients seen by primary care physicians, by nurse practitioners, by social workers working in a variety of different ambulatory settings. And here you get a sense of the imperative that I'm talking about, with 63% of patients with cancer, 60% of patients who visit cardiologists, the majority of people who see urologists and ophthalmologists, all being 65 and over. And even if we get into the area of hospital care that is intensive care, we have seen a marked change in the number of people who are 65 and older who come to these facilities. For example, these are data from ICUs where 46% of patients in critical care are now 65 and older, and they account for 50% of ICU days. And we worry about these patients because they do get treated differently than younger patients, some of which is very good, but some of which we worry about, including evidence that in these settings and also in the emergency room setting, some older patients receive less aggressive care than younger patients. We are also seeing in healthcare the phenomenon where the federal government and state governments are trying to cut down expenditures for healthcare, and the Centers for Medicare and Medicaid, which administer Medicare and Medicaid, have taken one step to try and decrease costs, especially related to hospitals, by no longer reimbursing hospitals for preventable hospital errors. Now, there are many hospital errors that CMS identifies for which they will not reimburse for services, but there are 3 of them where the prevalent errors occur in patients 65 and older, and these are falls, urinary tract infections from inappropriate catheter use, and stage 3 and 4 pressure ulcers. So we're now seeing that the federal government and the state governments are beginning to say one way to cut costs is to not reimburse for certain occurrences, including preventable hospital errors. And many of these errors occur to a large extent in people who are 65 and over, and of that population, they occur more commonly in people who are old, or 75, 80, and 85 and over. Now, these issues would not be so of concern if we felt that there was no science to geriatric care, and if we didn't have evidence that by really paying attention to care of older adults and knowing best practices and evidence-based practices, that there would be no difference. But that is, in fact, not the case. We do now know that geriatric competence of healthcare professionals improves outcomes for older adults. And there are many studies now that are available in the literature that show that if healthcare professionals have been prepared in geriatrics, if they follow geriatric protocols, if they know geriatric best practices, this care results in decreased mortality, reductions in disability and illness, improved patient and family satisfaction, improved quality of life for the older adult, including improved end-of-life care, and decreased health care costs. So it is imperative that healthcare professionals taking care of older adults know about the state of the science of the care that they are delivering. And that is one of the impetus for the geriatric education centers and for the development of this module. So now let us begin to look at the 4 areas that we were going to talk about today, what they are and how they impact on the care of older adults, and what kinds of things you as healthcare professionals should be thinking about as you take care of older adults in relationship to these 4 areas. And the first area that we are going to talk about, the first risk factor that we're going to talk about that contribute to poor outcomes in older adults, is iatrogenesis. Iatrogenesis is a very old concept. It's written about in the ancient literature, and it comes actually from a Latin term, which means a condition that's brought forth by a healer. So this is a condition of ill health or an adverse event which is actually caused by something that we do as healthcare professionals, not on purpose, obviously, because that's really not what we're talking about here. This is something we do because we're misguided in the decisions we make about how to treat an older adult. And iatrogenesis usually describes an adverse event such as, for example, delirium that may occur secondary to a medication that we use with an older adult, which we either should not be using because it has known adverse events with older adults. For example, Demerol and its known adverse events with older adult, or because we're using it we're using this medication at the wrong dose, or we're using it with timing that isn't accurate, or we're using it in combination with other medications, all of which contribute to the development of delirium. A second example of iatrogenesis would be dehydration, which occurs secondary to keeping an older person NPO, not giving them fluids. So, for example, we schedule somebody for some sort of a test, or we see an older adult in the emergency room. We're not quite sure what's going on with them, and so we decide to keep them NPO. But as a consequence, a misguided consequence of that action, the older adult becomes dehydrated. And because the older adult is very prone to dehydration, and again, specifically the older adult who's frail, who's very old, who may not have been drinking adequately at home, that person develops dehydration that sometimes goes unrecognized. A third example would be weight loss secondary to long periods of IV fluids. Again, we have somebody after surgery, we keep them NPO and on IV fluids, perhaps too long because we're not quite sure if they're able to tolerate food. They begin to lose weight, but they're already at risk from weight loss because, for example, they're very frail, they weren't adequately nourished at home, and so that weight loss becomes more profound than it might be in a 35-year-old who's well nourished when they go into surgery. And the last example, and there are many other examples, many of which I'm sure you're aware of in your own practice, that would be classified as iatrogenesis, is urinary tract infections that occur secondary to catheter use. So here we have a situation where we have an older adult, for example, post-surgery with a Foley catheter. We are not as diligent as we might be about removing the Foley catheter in a timely manner. The person develops a urinary tract infection. That urinary tract infection is what we would call an iatrogenic event. It's occurring secondary to a treatment that we have put into place. So those are examples of iatrogenesis. Cascade iatrogenesis is what happens when we start this process. We have an unintended consequence of a treatment, and rather than recognizing that it's the treatment that's the problem, we add another treatment because we think that it's something happening new to the patient. So it's an unintended decline of health from a series of severe effects caused by our multiple medical interventions that we've used to solve the previous symptom of condition. And here the example that we're giving is somebody who's developed delirium because of one medication we've added, but we don't understand that that's the cause of the delirium, so we add Haldol to try and manage the delirium, rather than removing the original cause of the delirium, which might be another medications. So we sort of add on new treatments without dealing with the original problem and throw somebody into what we have come to call cascade iatrogenesis. Iatrogenic complications are extremely common in hospitalized older adults, and especially common in older adults of advanced old age, especially those who have complex illness and long lengths of stay in the hospital. And you're going to see this throughout this presentation, that these areas of risk tend to overlap. So the person who's at greatest risk for iatrogenesis is the older adult who's quite old, in their 90s, who's already frail, may have other geriatric syndromes, which we're going to talk about a little later in this module, and also who may present atypically. That is, they don't present with the kind of symptoms or constellation of symptoms that we tend to associate with a particular disease or a particular disability. And many of these older adults not only have physical illness, functional illness, but they also have cognitive impairments, which places them at greater risk. So if you were to flag somebody who you're taking care of in the nursing home, at home, in the hospital, who's most likely to get an iatrogenic complication, it would be this very frail, rather old adult who's come into the hospital with complex illnesses, who you've not been able to discharge in the normal manner in terms of 3 or 4 days of a hospital stay, and who tends to be very frail and have both physical and cognitive comorbidities. How to recognize iatrogenesis? Well, the first thing I think is to really be aware that it happens, because I think we tend to forget that we can, in fact, through our treatments, cause negative consequences to the patient or the resident. So when something is not going right, just having an antenna up in your head that says, is this a new problem that the person is developing, or is it a problem that's a consequence of a treatment that we've already put into place? So you should consider iatrogenesis if the signs and symptoms that somebody has continue, or if they worsen after starting a new treatment. So has the person become delirious in the hospital after you've just started a new medication? Is the person having abnormal vital signs? And you have to really check and ask yourself, is this person NPO? Is this person possibly dehydrated and evidencing some abnormal vital signs secondary to dehydration? Does this person have unexplained pain that may be resulting, for example, from the fact that you've placed the patient on a medication that's causing constipation? And so by having caused the constipation, which is, as you all know, very common, for example, with narcotic analgesics, has the person now suddenly got abdominal pain? And rather than starting an extensive abdominal workup, can you begin to think about whether this is something that is resulting from a treatment that you have already put into place? So, as a critical thinking point to prevent iatrogenesis, ask yourself, is this a new onset of a sign or symptom? And if yes, could it be considered an outcome of a previous intervention rather than a totally new disease process or a totally new set of symptoms that are related to changes in physiology in the older adult? And I would say to you, this is not always easy to do in terms of recognizing this, because, as I've said, these occur in older people with complex illnesses. So it's very easy to jump to the fact that this is a new cardiac condition or a new abdominal condition or a new GU condition. It's very easy to make that leap. And it's your job, if you're going to think about iatrogenesis, to put sort of the brakes on that and say to yourself, maybe it isn't that. Maybe it's a consequence of something that we have been doing. Preventing iatrogenesis, well, first of all, to expect it, to really have it high up on your list of possibilities when you're doing a differential diagnosis or when you're listing your problem list for an older adult. Be vigilant in detecting and monitoring and reporting important and unexplained symptoms. And as I said before, picking out older adults who are likely to be at high risk for iatrogenesis. Those who are 80 years of age and older are frail with multiple comorbidities and exhibiting other signs of geriatric syndromes, and also making sure that the whole healthcare team is aware of iatrogenesis and considers it as part of their normal plan of care. Let's move on now to the second risk factor that we've alluded to here, that we want to discuss in this module, and that's the risk factor of frailty. Frailty is a relatively new concept in geriatric care, and it is a concept that is currently being described. The conditions that make up what we think about as an older adult who's frail are just now being tested to see how well they fit the concept of frailty. But it's a condition seen in older patients, and as I said, the old predominantly. It's characterized by low functional reserve, easy tiring, decreased libido, mood disturbance. There's an acceleration of osteoporosis, decreased muscle strength, and a high susceptibility to disease. And it can be manifested by characteristics such as muscle weakness, slow walking speed, exhaustion, low physical activity levels, and possibly unintentional weight loss. So these are, if you think about older adults that you see in the community who you take care of in ambulatory care settings, in your institutional care settings, these are the people who really look old when you tend to think about them. They sort of fit not the picture of the surfers that I showed you before, not the picture of the three friends who look exuberant and very much engaged in life, very much looking to the next adventure. These are people who tend to fit our stereotype of what an old person would look like. Slow moving, with some mood disturbances, not very much engaged in physical activity, not very much engaged in the normal interaction with the outside environment that most of us are engaged in our life, and that most older people are engaged in, even in their 90s and 100s. So just to be very clear, this is not a normal consequence of aging. This is a condition of aging which is not a normal, it's an abnormal condition, not a normal condition of aging. Frailty is now being described as an at-risk condition. And that is because people who are frail are compromised. They have compromised reserve. Their respiratory status is compromised. Their functional status is compromised. Their cardiac status is compromised. So they start from a condition of sort of being behind the eight ball here. They don't have the normal reserve. So if we do things to them, such as bring them into the hospital, even for something relatively minor, or if they have a condition that, such as the flu, or if they become minimally dehydrated, it tips them into a condition that makes them much more at risk of untoward events and negative outcomes. And this is just one example of that, and some studies that were done with frail older adults. So in the hospital, we tend to put people to bed, And unfortunately, we don't tend to ambulate them or to think about getting them out of bed nearly as quickly as we should. So in one study, it was found that over 70% of hospitalized older patients were able to walk, but did not do so during a 3-hour period. So these were older patients in bed. People got them out of bed. They were able to walk, but they, for some reason, either had orders for bed rest or somebody had not ambulated them during a 3-hour period. And we began to, the people who conducted this research began to ask themselves, why do these patients continue to have orders for bed rest despite the evidence of adverse events for everybody who has bed rest, not just frail older adults, but particular negative consequences for older adults who are frail? And why don't we ambulate these people so that they can recover whatever functional status they had as quickly as possible? And so in this particular study, they took 100 frail elderly people in 10 weeks and put them on progressive resistive exercises and better nutrition. And what they were able to show was that in 10 weeks, by taking a more aggressive response, a more aggressive attitude to older adults, they were able to increase their muscle strength, increase their gait velocity, increase their stair climbing power. So what I guess I want to emphasize with this slide is frailty is not something that cannot be reversed. You may not be able to reverse all aspects of frailty, but even in frail older adults, taking a positive stance in terms of mobility, in terms of exercises, in terms of nutrition, in terms of creating an environment where the person has opportunities for communication and staying alert, you can, in fact, either minimize the consequences of frailty and in many instances, reverse some of the evidence of frailty, even if the person still remains frail, but they do much better than they had if you don't take these steps. So we want to leave you here with a notion that frailty is something to identify, not just so you can write it down in a chart, but so that you begin to think about what positive actions, what are the evidence-based approaches that you can take to these older adults that can minimize the frailty and reverse some of it. Excuse me. Assessing frailty. Assessing frailty is, again, an area that is currently under discussion about how to best put into practice how you would identify those people who are frail in your setting. The one checklist includes the patient's age, that is, people who are 85 and older, the number of chronic illnesses they have, the number of medications that they take, and any unexplained loss or decline in functional status. So if you were to pick out people of excessive old age, who have, say, 5 or more chronic illnesses and who take 5 or more medications and have had in recent times an unexplained loss or decline in functional status, these were certainly people who you would want to work up to see if they were frail. There are some instruments out there to help guide you in how to identify and assess older people who are frail. Some of these tools are for individual practitioners. Some of them are for hospitals to put into their policies and procedures. But certainly these are patients in your settings who are at risk of untoward events as you take care of them, and who are people that you want to really pick out and monitor very carefully to make sure that they don't fall between the cracks in terms of assessing them on a continuing basis. Geriatric syndromes are the third area that we wanted to talk about today as an area of conditions that put people at risk for untoward events in all healthcare settings. And geriatric syndromes refer to one or more symptoms or a complex of symptoms which are very common in older adults. And you're going to see from the list that I'm going to give you in just a minute that these are not conditions that occur only in older adults, but they are conditions that occur more commonly in older adults, and which, when they occur in older adults, because especially again the old, because these people are at increased risk to begin with, a geriatric syndrome tips them over into having a much more major negative consequence of an illness or a treatment. They result from multiple diseases and risk factors. They're broad categories and signs of symptoms. They often have more than one cause, and they often limit the person's activities of daily living, and therefore reduce their quality of life. The American Geriatric Society, and we've given you the website here on this slide, has developed a list of geriatric syndromes. And I'm going to show you what's on their list, but I'm going to point out ones that we tend to encounter excuse me, in the healthcare settings where we work, which are somewhat under our control and which occur quite frequently. So, difficulty walking, dizziness, fainting, but I would pull out falling as a geriatric syndrome that we see quite commonly in older adults, and which is of grave concern in older adults. If you have an older adult that's coming in who's falling relatively frequently, because this is a condition that often precedes or is a prodromal evidence of something more serious happening in the older adult. So, for example, we will see people who are falling, and it's the first symptom of a severe GI condition, or the first symptom of a cardiac condition. So falling is a major geriatric syndrome that we see in older adults. Hearing problems, vision problems, bladder problems, incontinence is another geriatric syndrome that I would pull out for you, that is a major condition which we can actually do something about, because often it's related to some of the treatments and some of the care that we're giving in older adults. And I'm going to go back to that in a few minutes. Other geriatric syndromes identified by the American Geriatric Society are thinning bones or osteoporosis, pressure ulcers, which again is one that we see quite commonly with older adults. Luckily, we don't see pressure ulcers commonly generally, but when we see pressure ulcers, we especially tend to see them in older adults. Delirium and dementia, very common in older adults, and geriatric syndromes that we tend to think about as ones that we worry about a lot. Difficulty swallowing, sleep disturbances, slowed cognitive processing. So these are the list of geriatric syndromes developed by the American Geriatric Society. There's quite a bit of supporting evidence for geriatric syndromes, and when they occur, they put people at increased risk for delayed healing, delayed discharge from the hospital, a worsening set of conditions that can lead to iatrogenesis, and often associated with people who are themselves quite frail. So going back, we've chosen these 4 areas, just let me emphasize that. We've chosen these 4 risk factors to discuss together in this module because they tend to occur together as a constellation of symptoms. You see a frail older adult, they're more prone to iatrogenesis, they're more prone to geriatric syndromes, and they're going to be more prone also to the last area we're going to discuss in a few minutes, which is atypical presentation of illness. So these are constellation of conditions. We're describing them separately so you can understand them, but they tend to occur one building and feeding, if you like, on the other. Again, there's quite a bit of evidence for geriatric syndromes in older adults. Urinary incontinence in advanced old age can occur secondary to physiological changes of aging. It can occur secondary to iatrogenesis. It can occur secondary to frailty, or it can occur secondary to a disease process. It is you see urinary incontinence in people who are not elderly. You see urinary incontinence, for example, in postpartum women or women that have had multiple cesarean sections, multiple vaginal deliveries with tears and so forth. But again, it's much more common in older adults, with one study showing that up to a quarter of people 65 and older having evidence of urinary incontinence. And of course, when you get to the very frail older population in nursing homes, up to 2/3 of older adults having urinary incontinence when they live in nursing homes. So this is a geriatric syndrome that's quite common. I want to emphasize to you as we talk about these geriatric syndromes that you should not see them as a normal consequence of aging. It isn't normal for an older adult to be 90 and have urinary incontinence. What we're trying to emphasize here is that you should be looking for the cause of the urinary incontinence. Similarly with falls, it's not a normal consequence of being 90 or 95 years of age that somebody falls every 2 days. It behooves the healthcare professional who's taking care of this older adult to really explore, why is this person falling? Is there a physiological change that's contributing to this, such as muscle weakness in the lower leg? Is there an iatrogenic reason for this, such as the fact that the person's taking a medication that makes them prone to orthostatic hypotension and they fall? Is this a consequence of the older adult being frail and needing physical conditioning exercises? Is it secondary to a disease process going on where the disease process hasn't really declared itself yet, typically the way we see it? Is this a sign, for example, of somebody having a myocardial infarction, but they're not presenting with, chest pain radiating to the arm? They're presenting initially by falling. So each of these geriatric syndromes, falls, urinary incontinence, delirium, should be viewed as a reason for a further workup, not to just be accepted as a normal consequence of aging. And I want to specifically highlight medications because medications are often the prime offender contributing to geriatric syndromes, and by the way, also to iatrogenesis. So adverse effects from medications in adults of advanced old age can contribute to cognitive impairment, to instability, to urinary incontinence, to falls. And there are some medications that are really absolutely contraindicated in older adults. And if you go to one of those websites that I showed you originally in this module, consultgerrn.org, and you go to the Try This assessment instruments that are on the resource button at the top of Consult Jerry RN. It will give you a drop-down menu with all sorts of assessment instruments, assessment for delirium, assessment for falls, and one of the assessment instruments is the Beers medication instrument, and it was developed by a physician, Mark Beers, and it gives you a listing of medications that are highly contraindicated in older adults, and it explains to you the medication to medication interaction that can occur when you use these medications. And so the population of older people who should not be taking certain medications. So I'm highlighting for you here medications with geriatric syndromes. I hope I made that case with iatrogenesis. Also, medications can contribute to the development of some of these conditions, and they're wonderful things to think about first, because if you can actually do something about them in the next 5 minutes. You can discontinue the medication, you can lower the dose of the medication, you can spread out the time intervals between the medications. This is something which you can really say to yourself, maybe this is due to a medication, maybe this iatrogenesis is due to a medication, maybe this geriatric syndrome is due to a medication. And so you can begin to work with that almost immediately and see the consequences of whether the patient's condition improves. The last of the conditions that we wanted to talk about in this module is what's called atypical presentation of illness. So along with iatrogenesis and frailty and geriatric syndromes, atypical presentation of illness puts an older adult at risk for bad outcomes. And that is because when the person presents with an atypical presentation, we don't always seize on the fact that this is a hallmark of something bad happening with the older adult, but it's happening in a way that we're not used to seeing. So in older adults, atypical presentation of illness includes a vague presentation of illness. The person might say, well, I don't know, I just don't feel right. Or I don't know, my breathing just doesn't feel right. They're vague about the symptoms they're having. They can't pinpoint. They don't have point tenderness or a particular place that this is hurting, but it just is vague. It's global rather than specific. The second thing that you see is that it's an altered presentation of illness, and the one that I've described several times is the person who has, for example, abdominal symptoms, indigestion, when they're really having a myocardial infarct. And the third atypical presentation is no symptoms, so that you see an older adult who's actually having something quite serious happening to them, but they don't seem to have any of the normal symptoms that you associate with that condition. Atypical presentation is commonly reported in older adults with infections, with heart conditions such as myocardial infarct and congestive heart failure, and in people who are also having urinary incontinence, where they may just not describe very much or describe a little bit of urinary leakage. They can't really describe what this incontinence is about. So atypical presentation of illness is one that you have to have your antenna up for, because if you just think these are minimal symptoms that don't have any real consequence, you have the risk, you are at the risk of missing something that's going on with the patient that is much more serious than it appears to be. Classic symptoms and signs of atypical presentation would be acute confusion, failure to eat or drink, failure to develop a temperature or fever even when the person has an infection, lack of pain with a disease which is normally known to cause a lot of pain, such as a gastric ulcer, some sort of functional decline, the person, or reduced mobility or generalized weakness. The person says, up until a week ago, I was going to the senior center, I was participating in the aerobic dance class at the senior center. Now, I don't know, I'm just not doing those things. I don't feel well enough to do those things. They can't localize a particular area that they're having problem with. They can't tell you that they have chest pain or abdominal pain. They just have generalized malaise and not feeling well. Falling, fatigue, and urinary incontinence. These are some of the classic signs and symptoms of atypical presentation of illness. And again, if this is an area that you would like to look at in greater depth, if you go to the website consultjerryrn.org, there, and again, look under resources, there are protocols, a series of protocols, and there is a protocol on atypical presentation of illness that would give you more information about this if this is, and also you can obviously just Google atypical presentation of illness. You'll get a lot of information, but this is an area that you want to think about because it occurs in other people, but it occurs much, much more commonly in older adults, and among older adults, the old. Now, I want to spend the remainder of the time in this module talking a little bit about the older adult who has both chronic physical illness and also has cognitive illness. And in this particular module, I'm going to focus on dementia. We have many older adults as they get into old age who evidence dementia. If you look at people 65 and older, generally, only about 5% of people 65 and older have dementia. If you look at people 80 and 85 years of age and older, somewhere between 15 and 25% of people have dementia. So again, I'm going to emphasize, dementia is not a natural consequence of old age. Not everybody, even if you live to be over 100, has dementia. In fact, less than 50% of people who are 100 years of age have dementia. However, dementia does markedly increase as people age. And people who have dementia also have a lot of chronic physical illness. And so this is just to give you one example of that. Almost 95% of people with dementia have at least one other chronic condition, and this is to give you a sense that of people with dementia, 30% of them have coronary artery disease, 21% have diabetes, and by the way, many of them have all of these conditions. So it would not be unusual to see an older person with dementia who had both congestive heart failure and chronic obstructive pulmonary disease and diabetes. So you have people who have multiple physical comorbidities and have dementia. The point I would specifically like to make in this module is that having dementia on top of chronic illness puts people at much greater risk of bad outcomes. So I'm going to say that again. Having an older adult with multiple chronic illness who also has dementia puts them at much greater risk of having poor outcomes, greater morbidity, longer lengths of stay in the hospital, more likely to be readmitted to the hospital after they've been discharged, much higher cost, healthcare costs, than if they only had physical comorbidities. And I can give you sort of an example. If you're an older adult with just congestive heart failure, as you have a length of stay of a certain number of days. If you have congestive heart failure and dementia, your length of stay is 3 times longer than if you just had congestive heart failure alone. So the people, we've been talking about iatrogenesis and frailty and geriatric syndromes, and I would just now like to add to this picture that the people who have dementia and chronic illness will be much more likely to get these conditions, and they'll be much more likely to be underdiagnosed in these conditions, and they'll be much less likely to have good treatment with these conditions. So dementia is an added risk factor, and it is something you just need to think about. If you're working in nursing homes, for example, where a large number of the residents that you're taking care of have dementia, you need to factor that in when you're thinking about their care in terms of, are they likely to present, for example, with an atypical presentation of illness? Absolutely. Are they less likely to be able to describe their symptoms than somebody without dementia? Absolutely. Are they more likely to have iatrogenesis because we don't really understand what's happening? When they don't get better, we just add another treatment? Absolutely. So this is very much of an at-risk population that you need to be thinking about as you're sort of trying to process what's in this module. There are many good assessment instruments for cognitive impairment, and here again I would refer you to the Try This series on the Hartford Institute website, Consult Jerry RN. That is our clinical website. And we have a general Try This series, and we have a dementia assessment Try This series. And if you go to that website, you'll see them clearly identified. And I've just pulled out a couple, some of the instruments that specifically relate to cognitive impairment. So, for example, there's an instrument to look at, to evaluate executive dysfunction, which is an early sign of cognitive impairment. There's the mini-cog, which is a good screening instrument for dementia. There's an instrument to look at a quick screening for dementia in hospitalized older adults. There's an instrument, the CAM, for delirium. There's the geriatric depression scale. And there's a specific assessment for delirium in persons with dementia. So I urge you to take a look at these if you think they would be helpful. Finally, I just want to alert you to the age bias in some of the practice guidelines that you're using in your practice setting. There are many very good practice guidelines for managing conditions and for assessing and managing very many conditions in older adults, heart conditions, respiratory conditions, GI, neurological conditions. I just want to alert you that most of these guidelines have been prepared with using older adults who are healthy or relatively healthy. Many times older adults who are advanced old age have been excluded from these clinical trials. Certainly these trials often test their guidelines on older adults who have no cognitive impairment. So you should take these guidelines with a grain of salt when you're using them with a very older adult, because they often don't address the kinds of symptoms and management that you need to put in place with these older adults that we've been talking about, these very frail older adults. So I will conclude with this slide to alert you to the fact that we're very pleased that you've looked at this module. that we're very convinced that gaining the kind of evidence-based practice that we hope you've been exposed to in this modules will increase your geriatric knowledge and your ability to take care of the older patients who you encounter. Geriatric professionals are not born, they're made, and we hope that you will use this and other modules to increase your geriatric knowledge and competencies. And we congratulate you on completing this module, and again put our 3 websites up, all of which are access points for this and other modules of the CNY GEC. Thank you.